everyone. I am Dr. Fache Moses, a consultant obstetrician and gynecologist, a fertility specialist, and a minimally invasive gynecologic surgeon. I am the medical director of ProCare Hospital, and today I will be addressing some frequently asked questions to commemorate the World IVF Day, 25th of July 2026. So you're welcome. Thank you for your time. All right, so the IVF process has a series of phases that are intricately integrated, one taking off from the end of the other. Most of the time, people forget one of the most important phases, which is the pre-treatment evaluation phase. This phase is when the doctor or the specialist interacts with the couple. This interaction will try to understand the reason why they are seeking IVF, what's the reason why they are unable to conceive naturally. They undergo a lot of tests to determine their fitness for IVF. This is also the time you make a diagnosis. Are there factors to be treated? Are there conditions that need to be treated before the IVF? If someone has fibroid, is this fibroid going to affect implantation and therefore had to be removed, or is it the kind of fibroid that may not affect the treatment? If there are conditions like polycystic ovary syndrome, how is it going to affect the choice of protocol, the medication, the dose, and how long you're going to give it? All these decisions are planned in this stage, and both patients are optimized, especially the woman. If there is a medical condition like hypertension or diabetes, efforts are made to correct them before initiating the IVF properly. So this stage is very important and cannot be negotiated. So it's not a stage that you can rush through. This is like a farmer who is preparing for the planting season. It takes time to till the soil and ensure that the soil is properly prepared for planting. So that is the stage, one of the most important stage of IVF. And this is done a few weeks or months before the actual IVF procedure. Now, once this is done and the couples are ready, patient is ready to start, then the first stage is the ovarian stimulation stage. This is the stage where medications are given to help mature multiple follicles. This is in contrast to natural cycle, where one follicle develops and eventually ruptures to release the egg. In IVF, you want to have plenty follicles, as many follicles as are recruitable that are safe for the patient. So that's why they call it stimulation, like you are stimulating the follicles in the ovaries to all mature, as many as possible. And so in doing so, patients receive injections for about 10 to 12 days during the stimulation. As you're trying to stimulate the ovaries, you would also introduce medication to prevent premature ovulation. And so this is where, as we continue this conversation, you would hear about protocols where we give another injection that helps to suppress premature ovulation. They can be agonists, they can be antagonists, they can be progesterone. This helps to prevent premature ovulation so that the follicles can be available for egg retrieval. So once follicles continue to mature and you get to this stimulation phase is monitored usually with ultrasound, transvaginal ultrasound, to monitor the maturation of the follicles. And when you have follicles that have reached about 18 to 20 millimeters, then you would give the trigger injection. This trigger injection can come either in the form of human chorionic gonadotropin, called HCG for short, or the GnRH agonist. which can be used to trigger. So once you give this trigger, what the trigger does is that it helps the final maturation of the eggs inside the follicle and prepares them for egg collection. So egg collection is the next phase, which is usually done between 34 to 36 hours after the trigger is given. Using ultrasound guidance, it is usually done under light sedation. In the IVF theater, it takes an average between 15 to 30 minutes, depending on the number of follicles that are going to be aspirated. And so using a gentle suction and a needle with ultrasound guidance, each follicle is aspirated, and the aspirate is passed on to the embryologist, who check and then eventually announces the total number of eggs that are retrieved during the egg collection process. The next phase after the egg collection is the fertilization phase, where the eggs and sperm are brought together. This can be done if the sperm is okay using conventional means, where the egg and sperm are just put in the same dish and then fertilization occurs naturally. If there are issues with the sperm, maybe low sperm count or a lot of abnormal sperm, then we use the process we call intracytoplasmic sperm injection, ICSI for short, where the embryologist would select one sperm and inject directly into each egg. This is to maximize the likelihood that each of the eggs are fertilized by normal sperm, where you have few normal sperm. So these are the two ways that fertilization is achieved, either by conventional IVF or by ICSI. And then by the next morning, usually the embryologist will check to confirm the number of eggs that have been fertilized. So once that is confirmed, then the next phase is embryo culture. So once the egg is fertilized, you have embryo culture. This is the period where the fertilized egg, now which we now call embryo, is incubated under special conditions in the lab over the next 3 to 5 days, with the hope that most times we want the eggs, the embryos to get to day 5 or 6, where we expect them to have become a blastocyst. In some situations, especially where you have few embryos, and of course the embryos are monitored, and you may find that their development, they might not make it to day 5. So sometimes transfer is done on day 3, what we call the cleavage stage usually. So if you have situations that shows that the embryos may not make it to day 5, you can do a day 3 transfer cleavage stage. But if you have enough embryos, day 5 blastocyst is what transfer is what is the traditional commonly. So after the transfer is done using ultrasound guidance most of the time and soft catheter. 1 or 2 embryos are transferred into the uterus depending on this determining situations. And then, of course, after that, patient is placed on luteal medication. This luteal medication is mainly progesterone, which can be given either orally or by injection or by vaginal route, to pessaries that are inserted into the vagina. What is important is because of the way that IVF is done, there is no corpus luteum to provide this progesterone, so we need to supplement it. So we give this progesterone in this form, adequate enough to help the womb, prepare the womb for implantation. So this luteal support is usually taken up to pregnancy testing and beyond if the person tests positive. And then, of course, after embryo transfer, technically, that brings to the end of the IVF process. But of course, you need to do a pregnancy test, which is usually done at about 2 weeks on average after the embryo transfer. So that's where you have the 2 weeks wait. Embryos have been transferred, patient is on luteal medication, and then nothing is really happening, patient is anxious, and so 2 weeks later, she does the test, and then after pregnancy test, that is clinical pregnancy if the patient, that's a chemical pregnancy if the test is positive. Say it's chemical pregnancy because you're testing chemical. About 2 to 3 weeks after the pregnancy test, then we will do an ultrasound to confirm whether there is a gestational sac and a fetal pool. If we see gestational sac and a fetal pool, then that is clinical pregnancy. And of course, the patient can continue to be on this luteal medication depending on the policy of the IVF center. So this basically explains the whole process of the IVF cycle. It takes an average of 4 to 6 weeks depending on the protocol that is being used. Thank you. All right, so the concept of ovarian reserve is a measure of the fertility level of the patient. It gives an idea in terms, most importantly, a quantitative idea of how much more eggs a woman has in her ovaries. And so for us to understand ovarian reserve, we need to understand that women are born with all the eggs that they will ever have. At birth, they would have about 1 million to 2 million eggs in their ovaries. And then these eggs will continue to deplete, and by the time they reach reproductive maturity, that's what we call the puberty, this has dropped to about 300,000 to 400,000 in both ovaries. This, from then on, they will begin to ovulate and maybe ovulate 1 egg every month. But it is important to understand that it is not this 1 egg that is ovulated every month that is leaving the bank. They are losing hundreds of eggs on a monthly basis. And so this is how the eggs in the ovaries of the women will continue to depreciate. And for every woman that lives long enough, by the time most of them are clocking 45, 50, their eggs are depleted and they will go into menopause. So at every point in time, the amount of eggs that are left in the ovary determines what we can get during IVF stimulation. And so one of the common tests we want to do first and foremost is assessing the ovarian reserve of the patient. And so we'll be able to determine how much eggs we're likely to get, how is the woman likely going to respond to stimulation. And in this respect, we classify ovarian reserve into normal ovarian reserve, high ovarian reserve, we call them high responder, especially people with polycystic or ovarian syndrome or PMOS. And then some people have diminished ovarian reserve, especially women who are of advanced reproductive age. They might have very few eggs. So it helps you to plan your treatment. What kind of protocol are you going to use? What dose of medication you're going to use? The parameters we use to assess ovarian reserve first and foremost is anti-Müllerian hormone, which we call AMH for short. This hormone is secreted by the small antral follicles in the ovaries, and so a measure of this hormone gives us an idea of how the woman is going to respond to the stimulation medication. Usually a figure of between 1 nanograms per milliliter to 4 milligrams per milliliter, nanograms per milliliter is considered normal. If you have below 1, that's probably diminished ovarian reserve. And if you have above 4, that is high ovarian reserve. And this usually is common with women, like I said, with polycystic ovary syndrome, which is now called polyendocrine metabolic ovarian syndrome, PMOS. So that's the first criteria, AMH. And at this point, I need to mention that AMH as a hormone basically gives us an idea of the quantity of eggs. It does not measure quality, Because a lot of times you see patients say, oh, I did my AMH, my AMH is 1.5, my AMH is 1.8, so my reserve is good. And they forget that it is not just quantity that determines outcome of IVF. The quality of the egg is important. So a 30-year-old woman, for instance, who have AMH of 1.2 might have a better chance in terms of her outcome compared to a 38-year-old woman who has an same level of AMH because of the difference in quality of their eggs. So this distinction is important because a lot of time people are just paying attention to AMH as if it's that special hormone. My AMH is good. So it's important to understand that AMH as a measure of ovarian reserve is giving you an idea of the quantity of eggs that are in your ovaries. The next criteria or parameter that we use is what we call the antral follicle count. Antral follicle count are the small follicles in the ovaries that we can see on ultrasound. They measure between 2 millimeter to about less than 10 millimeter in the ovary. So we call them antral follicles, and usually measured in the early stage of the cycle. Between the 2 to 5 of the cycle, that's the best time to measure the antral follicle. And it gives you a direct estimate of, because the medication you're going to give for stimulation is expected to act on these antral follicles to help them to mature. So the amount of antral follicles you see at the beginning of an IVF cycle can directly give you an idea of what response you are likely to get if you use the right dose of medication. One of the other parameter, of course, that used to be used is FSH, which is measuring follicle stimulating hormone. But over the years, it's been found to be quite inconsistent. It fluctuates a lot, so it's not commonly used this day, even though we still measure FSH routinely as part of our baseline investigation. It's not as reliable as the combination of AMH and antral follicle count. Ovarian reserve, of course, and ovarian response is highly influenced by the body mass index of the patient, which is also important when you're considering the likely response of a patient to your stimulation. All right, so hysteroscopy is a minimally invasive procedure that allows us to use a tiny camera introduced through into the womb through the cervix to visualize the cervical canal and visualize the endometrial cavity, which is where baby is supposed to implant, where pregnancy is meant to develop. And so as of today, it is the most objective way to actually see directly the inside of the womb. And it's gaining a lot of popularity as part of the baseline evaluations for before IVF. However, when you look at it critically, it's still invasive, even though we say it's minimally invasive. It costs a significant amount of money. And so there are concerns or recommendations that if a woman's ultrasound is normal and there are no red flags, this woman has not had maybe miscarriage, she has not had any procedure done in her womb, she has not had maybe previous failed IVF, you may not necessarily need to do hysteroscopy for every woman that is trying to do IVF. Having said so, it's important to also understand that when we say normal ultrasound reports are very subjective because it depends on the experience of the person who is performing the ultrasound. It depends on the resolution of the ultrasound machine that is being used. It depends on whether this ultrasound is transabdominal or a transvaginal scan. And so one person may scan a woman and say, oh, the findings are normal. Another person will scan the woman and find something. So this is where the subjectivity comes in. What really makes a normal ultrasound? And so sometimes, most of the time, we're trying to use our high resolution ultrasound to evaluate the uterus. Sometimes we go on to do additional specialized ultrasound procedures like sonohystogram to further evaluate. We also do 3D ultrasound just to see if there are things, subtle abnormalities in the uterus that may need further evaluation. If we have any doubt that the uterus may not be normal, then we would usually recommend hysteroscopy, a diagnostic hysteroscopy. It's a short procedure. It can be done under light sedation. In fact, in the office setting, it can be done without anesthesia. And so it's just better sometimes to see, because we're seeing a lot of cases now where patients will have had a failed IVF under the premise of normal uterine cavity, and then you go and do hysteroscopy and you find that there were some subtle abnormalities that were not picked on ultrasound. So what is important is to highly select your patient. It's not something to say, okay, everybody that is coming for IVF come and do hysteroscopy, but you must be meticulous in selecting your patients. And for those who need it, let them understand the reason why you think they would need hysteroscopy. And so if you've had failed implantation, you have had procedure done in your womb, you have had a miscarriage, you've had a recurrent miscarriage, then you would benefit from of value. Hysteroscopy will be of value before your next IVF. And again, this must be done in centers and have the expertise with good equipment, because a lot of times, again, just like the ultrasound, clarity matters. So if you put that camera in the womb, it's just like you can compare this to the phone cameras. You know that the high-end phones have a very high resolutions that can show you details. So that's what happens in the kind of telescopes we're using for hysteroscopy. If you're not using a high-end hysteroscope, you might also not pick up some subtle abnormalities. And so you must ensure that the center where you're doing your hysteroscopy have high resolution equipment to be able to detect these subtle abnormalities. IVF protocols are is a measure of the combination of medications that we put together. I know in describing the process of IVF, we said one of the two major things you want to achieve is, one, to stimulate the ovaries so that you can produce, the ovaries can produce good number of mature follicles. And the second medication is to suppress the brain so that to prevent premature ovulation. That is the second thing you want to achieve. So the combination of drugs that you use for stimulation and this ovulation suppression is what we call the protocol. It's a mixture of these drugs. So the traditional protocol that, in the beginning, what was happening is what we call the natural cycle, for instance, where patients' natural follicles are followed up, and then that one egg that nature has selected is harvested and fertilized. Of course, the outcome was not very impressive. So in the beginning, we have the long agonist protocol, where the suppression, there's what we call down regulation. You start giving the medication in the cycle before the cycle you want to use for the IVF stimulation. So maybe from the day 21 of the previous cycle, you begin to give this GnRH agonist injection to help to suppress the brain and then and thereby suppress the ovaries before you start stimulating the woman. Does it make sense? So that is what we call the long protocol. So when the woman menstruates, you start the stimulation, and then you continue to monitor the follicles, eventually harvest the eggs when it is. So as the name implies, it's long because it may take up to 6 weeks from start to finishing, because first of all you start to give daily injection that suppresses, and then you now introduce injections that stimulates the ovaries. And so it's, as the name implies, truly long. That is the long agonist protocol. Now, over time, we found that, okay, you can still achieve this suppression using another kind of medication, which we call the antagonist. You would see that in most IVF protocols, the drug for stimulation is essentially the same in all of them. You're using either FSH, which is follicle stimulating hormone. When it has LH in it, we call HMG, that's human menopausal gonadotropin. Of course, there is also synthetic LH now that can be added to FSH. So FSH, that is common to most of the protocol. But what differs is the drug that you are using to suppress or to prevent premature ovulation. And so that is where most of the protocols get their name, agonist protocol, because you are using an agonist to suppress to prevent premature ovulation. In this antagonist protocol, you are using GnRH antagonist to prevent premature ovulation. And unlike the long protocol, in this antagonist protocol, the treatment starts usually from the second or third day of the woman's menstrual cycle. So you don't have to start giving injections in the previous cycle. You wait for the woman to start her menses, and on the second day or third day, you start first by giving the stimulation medication. And then on maybe after 5-6 days of the stimulation, you now introduce the GnRH antagonist, which would help to suppress the brain and prevent premature ovulation. So that is the antagonist protocol. It's short. Usually within 2 weeks from start, you are ready to collect the egg. So it is shorter. There is less injection, and is now becoming the more commonly used protocol. There's still a lot of people who use the long agonist protocol. There is also other, these are the two main protocol, agonist and antagonist. There are variations of this where you have the short agonist protocol, you have the microdose flare protocol, and then you have newer generation like what we call the progesterone primed ovarian stimulation, PPMOS. So these are different kinds of protocol we just explained. And so when we go on to talk about individualized IVF, you now realize that you don't have one protocol that is the best based on the question that you ask. So the job of a fertility specialist is to evaluate each patient and determine which of the protocols is best suitable. If you have a woman who is a high responder, maybe she has polycystic ovary syndrome, for instance, then your best protocol may be the antagonist protocol, because it allows you to use a trigger that may reduce the likelihood of the woman having OHSS, ovarian hyperstimulation syndrome. If you have a woman who has endometriosis, you may want to use the long agonist protocol, in that case. So it's difficult. So this is the one-size-fits-all protocol. So the variety of protocols we have is such that as fertility specialists, we can evaluate each patient and determine which of these protocols are best suitable. If you have donors that you want to stimulate, you can use the progesterone primed ovarian stimulation protocol. And then if you have women who have diminished ovarian reserve, you can use the microdose flare protocol. And so that's how it is. right, so dual stim or dual stimulation. Dual stim is just dual is just two, and then so the actual name is dual stimulation. They also call it the Shanghai Protocol because it originated from China. As the name implies, it implies achieving two ovarian stimulation in one menstrual cycle. Now, let me break it down. Traditionally, what we used to know is that when you want to do ovarian stimulation, you wait just like I've explained. So in the beginning of the menstrual cycle, either on the second or third day, you start to give your stimulation drugs. And then after 10 to 12 days of these drugs, you prepare the patient for egg collection. And when you collect this egg, you may either go on to transfer the embryos in that cycle, or you freeze either the eggs or the embryos, wait for the woman to menstruate, and then if you need to do another stimulation, you start again from the early days of the next cycle. This is what we do traditionally. And that is based on the initial understanding that follicle recruitment usually happens during that first phase of the menstrual cycle, which we call the follicular phase. In more recent time, we have come to understand that follicular recruitment happens in waves, during the menstrual cycle. And so it's not just restricted to the early phase of the menstrual cycle. Even during the at any time T of the menstrual cycle, there are waves of follicles that are being recruited. And so the current dual stim allows us to if you finish that first stimulation that you started on day 2 of the menstrual cycle, and maybe you end on day 14 of that cycle, you can give a few days, 3 to 5 days, and start another stimulation. So this traditional stimulation, we call it the follicular phase stimulation because it happens in the follicular phase of the menstrual cycle. Now, the second stimulation is called the luteal phase stimulation because it is happening in the luteal phase. That's the second phase of the menstrual cycle. And so you repeat essentially what you've done in the luteal phase, give your stimulation drug again for another 10 to 12 days, and harvest the eggs that you get at the end of the day. So in one cycle, you're able to achieve 2 stimulation and 2 egg collection. This has been, and of course, research have shown there were concerns in the beginning that maybe the eggs that we're getting from this second stimulation may not be as of good quality as the one we got from the follicular phase. But since its adoption, research have shown that the qualities are similar. And so it's not inferior to the follicular phase stimulation. The only thing is you cannot transfer in that cycle. So this kind of protocol or stimulation approach is reserved for situations where you want to pull eggs, like women who have diminished ovarian reserve. You may not get all the number of eggs you need to achieve a good outcome. So you are doing what we call egg banking or embryo banking. You do that first stimulation, collect the eggs, do another one, collect the eggs, and put them together and fertilize them. So women with diminished ovarian reserve can benefit from dual stimulation or dual stim. Women who are time constrained, maybe they are abroad, they don't have so much time to go and spend, they are limited in time, can benefit from dual stimulation because you can do this stimulation in one cycle. Most importantly, women who have medical reasons, women who have cancer, for instance, and are going to receive cancer treatment that may affect their fertility. Maybe the cancer, either radiation or medication, may affect their ovaries. They don't have so much time to wait. You need to get out eggs as much as possible before they are exposed to this cancer treatment, can benefit from dual stimulation or dual stim. Okay, it can help patients achieve the number of eggs quickly, but of course it has a psychological toll because you're going to be receiving injections for a longer period of time. You're going to have 2 egg collections, and you cannot have transfer in that cycle. So sometimes it can be emotionally tasking and demanding for the patient. Yeah. Yeah, as the name implies, freeze or is another innovation in IVF where, contrary to starting the traditional time where we start stimulation and aim to transfer the embryos fresh in that same cycle. Freeze or gives us an opportunity to say, okay, the eggs and embryos that we're going to be creating will be frozen, so there will be no transfer in that cycle. There are reasons why this may happen. Some of these reasons may be predetermined. Like in situations where people want to do genetic testing on their embryos. The embryos are created, biopsy is taken of the embryos and sent for testing. So during that period, the embryos necessarily will have to be frozen. Okay, a woman who have polycystic ovary syndrome, who is prone to developing ovarian hyperstimulation syndrome, may have her eggs, her embryos frozen because if you do a fresh transfer, then you increase the likelihood of the woman, the severity of the ovarian hyperstimulation syndrome. So it might be advisable in that case to freeze all the embryos, allow the woman to recover from the stimulation effect, and then you can transfer in another cycle. So there are also times, these are usually situations where the freeze all is planned and everybody understands. Sometimes we call it segmented cycle. Like you do the first part, which is stimulation, you are not going to transfer, do what you have to do. Either you are waiting for the patient to recover or we're sending the embryos for testing. And so when it is pre-planned like that, both patient and the fertility specialist are aware that this is how it's to go. And so everybody understands. Now there are instances where the need to freeze all occurs during treatment. Maybe the patient became sick during the treatment and you're able to harvest the egg. So you might want the patient to recover first before you go on to do transfer. Sometimes in the course of the stimulation, you may find that the uterus that seems to look normal in the beginning, maybe you are now seeing some kind of growth like polyp, things that you didn't see before. You are seeing that the lining is not developing well. You might decide to freeze all the embryos and transfer in another cycle. We also understand that, especially where you have used high doses of the stimulation injection, the estrogen may also, estrogen in high responders may also affect the implantation capacity of the endometrium. And so in such cases, you may also advise that the embryos should all be frozen. If these decisions are coming up if it wasn't discussed in the beginning, it's usually a challenge because it's going to cost a lot, additional amount to freeze the embryos, come and have a frozen embryo transfer cycle. So it's usually nice if these are taken into consideration and is discussed with the patient. Let the patient be aware that there may be need to do a freeze-off protocol. All right, so pre-implantation genetic testing, that's a situation. I think, first of all, we need to make a clarification because the name seems to imply that before implantation, but truly what happens is pre-transfer. Before transfer, that is doing a genetic analysis on the embryos before transfer, because if we see it as pre-implantation, we're already implying that, oh, the embryos are going to implant. Embryo transfer does not necessarily equate to embryo implantation. So I need to just make that clarification that what it means is genetically assessing embryos before transferring them. And so there are three main types of pre-implantation genetic testing. The first among them is what we call PGTA. The A, that's pre-implantation genetic testing, and neuploidy. Now, if you see that the normal chromosomal complement of a normal human is 46 chromosomes. So if it is more or it is less, then we say that is aneuploid. When it is 46, we say it's euploid. When it is abnormal, maybe more or less, we say it's aneuploid. So that's what the PGTA is meant to discover, and it's quite useful in cases of Down syndrome, women who are advanced in age, who are likely to have abnormal chromosomes. You want to assess the babies before the embryos before transferring them. And in so doing, he has also found application in gender, because by the time you are analyzing the chromosomes, you'll be able to determine, is this 46XY, 46XX? And so one other use is the fact that for people who want to do gender balancing, they are able to also determine the gender of the embryos before they are transferred. And it's becoming one of the very more desired way of determining gender of the fetus for gender balancing purposes. The second one is what we call the PGTM. M stands for monogenic disease, and this is particularly in cases where you have single gene disorders like sickle cell, cystic fibrosis, thalassemia. This pre-implantation genetic testing is able to determine, these single gene disorders. And for people who are maybe less in our environment, for instance, we have sickle cell quite commonly. So people who are carriers that have the risk of giving birth to a sickle cell baby can take advantage of this PGTM to determine the genotype of the embryo before transferring the embryo. So if the embryo goes on to implant, at least you are sure that you have prevented the transmission of that disease to the baby. The third one is PGTSR. SR means structural rearrangement. There are conditions that happen as a result of what we call translocation. The chromosomal complement is correct, but positions are mixed up. So we call them translocation disorders. And so that is PGTSR in the same way to prevent the transmission of such disease to the offspring. Now it's important to mention, because a lot of time of course, people who have maybe recurrent miscarriages, recurrent implantation failure may benefit from this PGT analysis, especially PGTA. Yeah, so having said so, it's important for people to know that pre-implantation genetic testing does not in any way improve the quality of the embryo, and it does not increase the number of the embryo. So it is not a test like people say, oh, are you going to run PGT as if it's just a test that tells you this is the quality of what you have. And so there is the possibility that you might send embryos and the result comes and say all the embryos you send are abnormal. And I have seen people who are not informed about this possibility getting very disappointed at the end of the day, like they have spent a lot of money, it's expensive, and only to be told that, madam, you cannot have a transfer because all the embryos are abnormal. And it's very, so even people who also want to use it for gender selection have ended up with the same fate, because occasionally they find that the gender of all the embryos sent is the gender that they do not desire. So it's important as part of counseling to let patients understand the usefulness of pre-implantation genetic testing and the challenges. What are the possible outcomes? So because and so that based on that, because it doesn't really it can help you to sort out, oh, this is abnormal embryo. Of course, sometimes there are results that come out what we call mosaic embryos. There's abnormality, there's normality, and then you are confused as per should you transfer, should you not transfer. So pre-implantation genetic testing is not recommended as part of routine IVF for normal responders. But for the category of these patients that I have mentioned, if you have recurrent implantation failure, recurrent miscarriages, if you've had history of an abnormal baby, then if you are of advanced age, then pre-implantation genetic testing may be beneficial in your treatment. So this is one of the emotionally leading questions of issues in IVF. When you get to that point where you have transferred the embryos, it's one of the period where nothing really is happening and there is a lot of anxiety on the side of the patient. Now, a lot of times patients feel that embryos, pregnancies have been transferred into them and they expect that immediately they should be able to see the sign of pregnancy, but that's not correct. So after the transfer, it takes some days, maybe 7, 8, 9 days for implantation to occur, depending on whether you have done a blastocyst transfer or a day 3, what we call the cleavage stage transfer. So we typically advise patients to test in 2 weeks. The idea that usually between day 12 and 14. The idea is to be sure that whatever test you're getting is what it is. At that time, because now implantation needs to happen. When you do that transfer, there is no implantation yet. So if you test too early, you may have either a false positive result. Now, let me explain. False positive result means that you are getting a positive pregnancy test when you are not actually pregnant. How can that happen? You remember that in the course of the stimulation, we have mentioned that when the follicles are mature, we give the trigger injection, which is in most cases is HCG. HCG is the pregnancy hormone. And so this HCG can stay in the woman's body for up to 10 days before it wears off. So if you are triggered with HCG injection and then you are testing too early, you might be getting weak positive tests from the HCG that was used to trigger, and you would interpret it as an early sign of success, only for the woman to be disappointed a few days later if the pregnancy test now becomes negative when she tests. Testing too early can also result in false negative test. False negative because you are testing when either implantation has not happened or implantation has happened, but the level of the pregnancy hormone at that time is still too low to be picked up by the pregnancy test kit. And so some women have, because of these false negative results, stopped their luteal medication, which is very essential for implantation to happen. So this is one of the reasons we try to discourage early testing, because it can go both ways. You can have a false positive result, you can have false negative result. So work with your clinic, stick with the advice of the recommendation of your clinic. If they tell you test in 2 weeks, test in 2 weeks. If they tell you you can test in 10 days, test in 10 days. There is no benefit of early testing because it does not, as much as we understand that, yes, patients are usually anxious, we need to know that early testing is not going to change anything. If you're going to be positive, you'll be positive. You're going to be negative, you'll be negative. But when you test early and you have either false positive or false negative, it can make you take the wrong decision. People have eventually, lost their pregnancy because they stopped their luteal medications too early because they got a false negative pregnancy test from testing too early. So, and then of course, in terms of reliability, blood test is the more reliable way to do pregnancy test compared to urine testing. Sometimes you see women with bag full of pregnancy test kit that they started testing from day one. After their embryo, they are testing their urine, and we need to find better ways to cope with that 2 weeks wait, so that we are not tempted to test too early. Thank you. The issue of IVF success and success rate is one that is very critical and nuanced in IVF. One, because there is no universally agreed denominator for calculating IVF success. I will break it down. And so when you ask somebody, what is your success rate? And then the person dish out a number. Our success rate is 80%. Most patients erroneously take this figure as a sign of, oh yes, 80% is excellent. But the question they are not asking is 80% of what? 80% of what? 80% of $1 is a lot much more than 100% of 1 naira. Correct? Yeah, so when somebody tells you 80%, and you are not asking what is the denominator, 80% of what exactly? So it's misleading, and maybe knowingly or unknowingly, many patients have been misled by this question, the answer to this question, which they think is one of the most important questions to ask a fertility specialist during consultation. What is your success rate? And then they get a figure. So the idea of breaking this down is like, first of all, there are several endpoints in an IVF treatment. So we will just quickly say, okay, one endpoint is, if you start with 100 patients, how many of them tested positive can be used by a clinic to say, we started with 100 patients, at the end of the treatment, one cycle, 80% of them, as 80 of them tested positive, so our success rate is 80%. Now, when you go, another endpoint is, when we did scan, how many of them did we see a heartbeat on their first scan? That's what we call the clinic. We talked about chemical pregnancy or biochemical pregnancy when you do the pregnancy test. Now, when you do ultrasound and you see a heartbeat, becomes clinical pregnancy. Some centers use that as their endpoint. Okay? And then there are centers who says they don't do antenatal care, for instance. So when they have monitored their patient who tests positive and have ongoing pregnancy, by the end of the first trimester, they are sending these patients to go to another hospital for antenatal. And so to them, they have recorded another success. So there are centers that says, our success is how many patients made it to the end of the first trimester. And then, of course, there are centers that say, okay, the patient who had come to do IVF came to look for baby and not necessarily just pregnancy. So our own success will be calculated on the basis of how many patients had what we call take-home baby delivered. So if you follow the conversation, you will know that as you go further, the success rate will be dropping. So if you have 4 centers and one of them is saying, out of 100 people that came, how many people test positive? Let us assume that 80 tested positive in the 4 centers. And one of them is holding on to it, so our success rate is 80. Now, as pregnancy continues, you go to the second one. Not everybody that tests positive would have a baby during ultrasound. Many of them will have early miscarriage, so they won't have a baby during ultrasound. So it means that maybe at the time of scan, only 60 now found baby. So the center that is using the number of people who saw baby on scan will tell you their success rate is 60%. Whereas the other one has already calculated their success rate. They didn't consider the fact that these other people didn't find not all the 80. Do you understand? So now if you go further, you find that even among the people who found where baby was seen during the first scan would not complete the first trimester before they have a miscarriage. So the people who are saying our success rate, we're going to use those who made it out of the first trimester, will still have a further lower rate compared to these first two people. And finally, the people who are using what we call the cumulative live birth rate, who are saying we are counting the people who gave birth after the IVF because it's baby they came to look for in the first, will have the least success rate, but they are not the worst IVF center. So if a doctor tells you our success rate and dishes out a number, you should be able to ask 80% of what? 40% of what? Now, when we go further, you would realize that success of IVF is also significantly a factor of age. And so if I have 100 25-year-old children, women that have IVF, the amount of them, the percentage of them that will get pregnant after the cycle is going to be much more than if, the collection of 100 38-year-old women. So I cannot use the percentage of those younger women to tell a 38-year-old woman to say, oh, our success is 80%. So if you're asking a doctor what's your success, and this doctor has not tell you that our success is stratified into age. And so you're telling a 38, 42-year-old woman your success rate is 80%. You're lying. So doctors do this either knowingly or unknowingly. Patients accept this information knowingly or and I've seen a lot of patients who regret the fact that, oh, we went to a particular center because they told us their success rate is 100%, 101%. Everybody that comes gets pregnant, which is not true. So for me, patients will have to do their due diligence to first of all, understand what true success. There are countries where there's a lot of regulation, so they're able to put their data, and so they can tell you average. What is the average IVF success rate in the UK? What is the average IVF success rate in America? What's the average success rate in a country in Europe? That will give you a better idea. So if a doctor is dishing out an information, just call you one number, then you should be suspicious because there is no one single number. So you should be able to say, yes, everybody that comes to our center, first cycle, if we have 100 patients, 80% of them test positive. And then you know that this success rate is based on on a chemical pregnancy rate. Oh, out of 100 people that comes, that is your age range, only 40% of them test positive, or only 40% of them we see baby when we do scan. So the discussion around IVF success rate is not a simple question of what is your success. And I see a lot of time patients are eager to ask this question. It's like you're asking somebody, are you good at what you do? What answer would you expect? So it's not, I think what patients should focus on is if you have interacted with a fertility specialist, and then you come to the point where you ask a fertility specialist, based on all that you know about my situation now, what is my chance of success with IVF? And so you have a honest conversation, so you can have a realistic expectation about what is your own chance. you cannot use somebody else's chance. You are using the chance of somebody that is 20 years to determine your chance that is 40 years or 44. You don't even have good quality eggs anymore, except if you're going to use donor eggs. These are the nuances. So I would like to encourage patients to understand the concept of IVF success rate. There are centers who start their IVF success rate. They even base their success on how many people started the cycle. Another center would say the success we are calculating is only the people that we transferred embryo, how many of them tested positive. And you see that all this, so if a center is saying, if I have 100 people and at the end of the day, 40 of them test pregnant, and I said positive, and I said, okay, my success rate for that is 40% using pregnancy test. Then another person comes and say, I am using my denominator is only the people that had transfer, and maybe 60% had transfer, and 40 of them test positive. So his own success will be 40 over 60, which is going to be higher because he has forgotten about the fact that originally 100 people started this treatment. So these are, aspects, and it's something that patients need to understand so you can discuss properly with your doctor. So this percentage that you have given me, how does it apply to me? I have endometriosis. Does it mean that my success is still the same thing with my age mate that does not have endometriosis? I have fibroids that I have operated. I have scar tissues in my womb because the fibroid operation had given me scar tissue. Is my success rate still the same as if I didn't have to have surgery? And I have polycystic ovaries. Is my success, so these things we need to understand them. So when you're asking any center or a doctor, what is your success rate? First, as a patient, understand what you're asking and be able to discuss further when you're giving that percentage. Say our success rate is 80%. So it means whether you have 40, 44, 45, 22, it doesn't matter. Our success rate is 80. And so that single number should be a red flag if you call a center that does not stratify their success based on age, does not go further to tell you what they are using as their denominator, does not go further to tell you that your condition, the cause of your difficulty in conception may also influence your success rate. Then you should be wary about centers that dish out single numbers as their success rate. I hope I've been able to address your question. All right, so thank you so much for your time. We've come to the end of this question and answer session. We have pulled these questions from the numerous questions that came from patients who are on their fertility journey who wanted to know more about the IVF processes. And I hope that my explanation would go a long way to help you in your decision. Don't forget that as part of the celebration of this year's IVF Day, at ProCare Hospital, we are offering 10 free consultations to 10 couples who qualify from the list. We may extend, depending on the number of input, we may extend it to, further beyond 10. But we're starting with 10 free consultations, and we hope that it will be beneficial to those who are going to get the consultation. Thank you.